applications, but I think there's been a pretty significant improvement in the technology and our understanding over the course of the past 10, 15 years. So I'm happy to describe some of my experience. Now, before McCracken gets a chance to say that the reason I like bone conduction implants is because I can never close a good air bone gap. That's actually not the reason why, but I'd love to tell you that all of my patients have perfect closure of their air bone gaps, but the fact is that they don't. Also, of course, the other indication of unilateral hearing loss, but they've really helped our patients out of a jam when previously it was kind of, well, you can try a hearing aid or try nothing, and that's pretty much it. So here are my disclosures. Both are peripherally relevant to this discussion. We're going to talk today about the history of bone-anchored solutions, the current indications, devices, pitfalls, and pearls. And for this group, which is all kind of otologists or neurotologists, residents with an interest in otology, the pitfalls and pearls are really going to be my own personal things that I've discovered over the years that hopefully will be relevant to you guys. Everything else is stuff that you probably already know, but doesn't hurt to have a little bit of a refresher. Oops, let me shrinkify this here. So history. So just because we've seen bone conduction in our world over the course of the past 20, 25 years, doesn't mean that it hasn't been known about. I love this picture here of a guy listening to the viola da gamba with his teeth pressed up against the curl of the top of the instrument so he can hear better. But so bone conduction has really been much older, and there's even some evidence from the 1st century where people could kind of tell the health of trees by putting their foreheads against the trees and tapping the trees, and depending on the different sounds that the trees made, give an idea whether or not they were hollow inside. And sure enough, bone conducting solutions as we know them are not novel. This is from the latter half of the 19th century. All sorts of patents out there. One on the very far left, where somebody would attach a metal rod to their thyroid cartilage, just on the outside, and then attach to either the patient's mastoid or to their maxillary crest. The audiophone, which I love the name of that, for the deaf, which is properly adjusted to the upper teeth. And then this one here on the right side is pretty cool. It's like a vibrating kind of a fan, and then the patient would bite down on it was almost like an antenna. It would bite down on this clamp over here on the right side. So all sorts of ways that we've known about osseointegration. And sure enough, those of you who are old enough to remember, and we still have patients like this floating around from time to time, there were bone conducting headphones before these quote unquote Bahas came out. Quick disclaimer: I'll use the term Baha. I know that Baha is a industry term for but I don't think we've all quite agreed on I call them osseointegrated auditory implants, but it takes too long to say that. So if I say Baha, it's not because I have any particular affinity towards one product versus the other, but for better or for worse, it's colloquially come to be known as that, kind of like Kleenex or Zipper, Xerox. So here's a picture of a bone conducting glasses. That was right after the transistor came out in the 20s, and then by the time that we were able to miniaturize it, put it inside glasses, they were able to make this hearing aid glasses where it kind of compressed against. And we've had patients like this. We've even seen, I'm sure you guys may even see patients who still have kind of the headphones on there. These are great. They actually work pretty good. The only difference is that it starts to hurt. It starts to hurt after a while. You rely on how much it compresses against your skin. But this is from December of 1954, and you can see how much has changed over the course of the last 66 years. So this is that picture on the left, and this is on the right, and this is a bone conduction glasses with wireless Bluetooth that you can get for $94. Not bad. Of course, you can't really program it like you can, with different frequency specifics, but and change the gain, but it's pretty cool nonetheless. And don't forget that Amazon is replete with these and aftershocks and other things that can really be helpful for people who may not have the financial wherewithal to get these things. So osseointegration, as it comes into the head and neck world, really started initially in the orthopedic world, and then Dr. Brannemark in Sweden was the first to apply it to the jaw for dental implants. Well, Dr. Brannemark and Dr. Chelstrom worked at the same institution, and Dr. Chelstrom said, "Hey, well, what happens if we put that inside the mastoid or near the mastoid?" And sure enough, in 1977, he did that, 3 patients, and then and then it changed and it grew and eventually was acquired by another company and then eventually acquired by Antific and then eventually covered by Cochlear. And that's what we know as the Baha. Interesting story about why it's called a Baha. I don't know if you've ever noticed, but it's not a B dot, A dot, H dot, A dot. It used to be called a B dot, A dot, H dot, A dot for a bone anchored hearing aid. But insurance promptly jumped on this and said, well, we don't pay for hearing aids. And this has got hearing aids right in the title. So Cochlear in their infinite wisdom decided to say, okay, well, it's not a B dot, A dot, H dot, A dot. We're just taking out the periods, and now it's called a Baha. It's just a made up name we gave it. So that was relatively clever, and I guess the people at the insurance companies are relatively dumb because they never really picked up on that. There have been frequent challenges to insurance over the years, and that's not really the scope of this talk, but I'm happy to talk with people about how we can get things approved. Right around the time that it was purchased by Antific was purchased by Cochlear, Patrick Westercole went over to and started his own company called Otorix, which is eventually acquired by William DeMount, which is a holding company of Oticon Medical. And in 2009, the Ponto system was launched. So in the percutaneous world, for a long time, there was just Bahas. And then in 2009, the Pontos came on. And for a long time, Ponto, I think Antific and Cochlear, they kind of rested on their laurels as their only game in town. And at least at our institution, we felt the technology, the Ponto was superior in the early parts of the 2010s. But then Cochlear caught up. There have been other bone conducting things out there. In 1981, Jack Huff founded Audient, which was acquired by Zomed and Medtronic. And every once in a while, you'll see a patient who's got one of these. I've never implanted one of these, but I have taken 1 or 2 of them out for cochlear implant patients. You guys all know how it works, so I'm not really going to get into that too much. Everybody here, I think, is a resident, at least, right? So I'm not going to get into this too much. Okay. Indications vary, of course, different insurance. You have your FDA indication and then you have your insurance indication. And as you may know from cochlear implants, the twain don't always meet. So try to stay as close to the FDA approved indications as much as possible, which for conductive hearing loss, you want the bone reserve to be better than 65 decibels on the affected side. Same with mixed hearing loss. But for the single side, your good ear has to be at least less than 45 pure tone average. I forget if it's 3 or 4 tone, but has to be better than 45 on your good ear. This is kind of a visual way of looking at that. And this is how you think about it. Are there exceptions? Sure. There's some people that I know we've fitted with worse hearing than this, and it's just sometimes just the better solution than other solutions that are out there. People over the years, sorry, this is a little blurry. It's not your eyes or your monitor. It's a little blurry. People over the years have tried to come up with different ways of how do we categorize these. We don't have great nomenclature. I always thought about writing a paper about just looking at all the different ways that people have described this class of devices, because it's all over the place. Bahas, bone-anchored solutions, osseointegrated implants, bone-anchored implants. It's zillions of different ways. We really don't have one standardized way of talking about it. It originally was kind of described as just direct drive because that's all there was. Percutaneous Bahas, which we know is the Baha, the Baha Connect now, and the Ponto. But there's also direct drives, which are these transcutaneous ones we're going to get into a little bit. This is how I like to think of it more. This is kind of my algorithm, not a algorithm, but more of a rubric, really. You got your percutaneous, which go through the skin, percutaneous, right, skin, and transcutaneous across the skin. And the transcutaneous are basically divided up to the passive and the active. The passives are kind of going away. I don't know if anybody's doing the Attrax anymore now that the Osse has been out. But we are going to talk about it a little bit. And I did a couple Sophonos back in the day. I'm not even sure this company exists anymore. I think it does. I don't know where they are right now. The Sentio, which is the Oticon medical bone conducting implant, is not FDA approved yet. So that's a disclaimer. I'm not going to I'll show it to you, but I'm not going to really talk about the efficacy per se. This is just a good picture of basically showing you what the percutaneous looks like. Very similar in general. I'll get into the relative differences between the two, but pretty straightforward. You got an implant, you got an abutment, you got your processor. implant, abutment, and processor. Frequently, when a single stage operation, which is most adults and many kids, it's going to be the implant and the abutment are going to be together as one unit, and you'll just implant them both together. Here's what the processors look like. We're out to new ones now. Sorry, I didn't update this, but you got your Ponto 4s, and I think we're up to Baja 6s now. We may even be up to Ponto 5, except for the superpower. And the Baja has a superpower that looks like this, suspiciously like their nucleus processor, but instead, of course, connecting to a transducer over here, it's connected to a vibrating kind of transducer, and those go onto the percutaneous hub. Now the technique has evolved a lot. Now, originally, back in the old days, I know that your faculty will remember the two-stage operation, and these were disgusting operations, and that was back when you could legitimately call it the perianal abscess of otology. These were awful. I hated these surgeries. These kind of gave way to one-stage surgeries, and these were done with full split-thick skin grafts or sometimes split-thickness skin grafts. And you had to undermine all the skin, and you had to use this weird little, actually it's actually pretty great, little dermatome, and you'd lift up the skin and you'd thin everything out, then you put the thing down and you bring the flap down, and I could tell you 0% of the time did it look this good, and 0% of the time did it heal that good. And you'd have small flaps and large flaps, and everybody tried describing different ways of doing it, and it never really looked good. And then somebody decided, I think it was maybe Holkrans or the group in Nijmegen in the Netherlands, first described a linear approach. And this is what I started doing pretty early on because I was so disgusted with the skin graft way that my whole career I've never done a skin graft because other than my training. But this was still also ugly. You'd make an incision and either put the abutment directly behind it or through it. And have to take out all this soft tissue, right? And you take out all the soft tissue. Now, in theory, these worked well, right? So audiologically, you heard great with these percutaneous ones. Skin reactivity was an issue, so it wasn't great. Cosmetically, it wasn't great. Subjectively, the patients were happy because they could hear good. The health-related quality of life was great. Sorry, the hearing-related quality of life was great, right? But the cosmetics not so great. So overall, good, but not great. But I love this, Pinocchio's Facebook photos. But if somebody, when people only showing you their post-op, their good post-op images, they're not showing you their bad post-op images. So you'd get some really disgusting, nasty-looking stuff. And these were tedious surgeries. They take like an hour to do. They delayed hearing. You'd have to use bolsters. There'd be graft necrosis. You never knew where the skin was going to end up lying. It'd get chronically infected. The fact of the matter is that this type of surgery went against everything we know about tissue respect. What they teach us early on in residency, even the dumb plastic surgeons know that you have to really treat the tissue with respect. So the minimal amount of manipulation of the skin that you can do, the better. And the thing that really made this possible was the development of longer abutments and the stability of longer abutments. And this was, I forget exactly when this was, but it was probably the mid-2000s, early 2000s, mid to late 2000s. And people said it couldn't be done because how can you possibly put a longer abutment in but maintain the same stability? But it turns out with osseointegration, you can. The bone grows into those threads, and you can actually have quite stable. I mean, imagine, people would think, well, if you're putting a flagpole into dirt, the bigger and longer the flagpole, the more likely it is to get knocked out. Yes and no, but you're not putting it into dirt. You're putting it into concrete, right? So putting that flagpole into concrete that may only be a foot long, you could still have a 30-foot long flagpole. So because of that, in my mind at least, that really opened up to doing really super minimally invasive procedure. And for basically my entire career, I did linear for about, I think, up until 2009 when this became available. And then after that, I said, screw it. I'm not putting in a 6mm implant. I'm going to put in 9mm implants and 12mm implants. They go up to 14 depending on the company. You may not want to do it all, but if the skin is less than, I'd say, 12mm in thickness, then minimally invasive is the way to go. So when your skin is less than 12mm or less, and I'll show you how you can measure that, this is really all you need. And theoretically, you could do this in the office. I've done revisions in the office. I have a colleague of mine who I know does them in the office. Insurance doesn't pay for it in the office, and there's some patients you wouldn't want to do in the office, but if the patient's a cash paying customer, totally reasonable, do it in the office. I mean, you guys are otologists, neurotologists, residents, a little bit of bleeding from the skull shouldn't freak you out. Even exposure of dura, even a CSF leak, I'll get into that, why that's not a big issue. So all you need is a little local sedation, maybe some data sedation depending on the patient. Headlight, loops, I don't use loops. Sterile drape, good to keep the sterile. A ruler, the drill, of course, the drill bits. Now they are kind of the way that I like to use the Oticon medical ones, and they're all kind of prepackaged in one little kit with a cannula. The implants and the abutments come together as one. Sleepers for kids or for people who might be more at risk for failure to integrate. Speaking of which, historically speaking, the loss rate, I think in the biggest published series in the meta-analysis, about 1 in 24 implants will get lost. Not the abutments, but the actual implants. And I don't think it's cost effective to put in sleepers for the 23 out of 24 who don't need it. So I don't put sleepers in people unless I think they have risk factors for loss, and that would be history of radiation, poor healing, thin skin, children, real young children. So to move on, I use a 6mm biopsy punch. 5mm. I used to use 6, but now I'm down to 5. You can do everything pretty good there. And then just the rest of the kind of something pointy to kind of make sure that you're down on the bottom. The fact is you don't really even need, because if I'll put a 4mm abutment even if the skull is 3mm thick. Why? Because you're going to get osteoneogenesis, and it's going to kind of form a little callus around that area. Screwdriver usually not needed, and torque wrench I like to use that at the end to confirm that it's nice and tight in there. So one thing that I should say about the size is that when we first started doing these, I should say that I'm one of the first, but I was not the first person to describe the simple punch technique. A guy named Mike Novak had been doing that in Indiana for years before I started doing it. Illinois, Carl Clinic, Illinois. Thank you. Right, one of those flyover states. That's terrible. People, one of the initial concerns with this is that how can you see what you're doing? You can't see what you're doing through a 5mm little tunnel. Actually, you can, and even if you can't see perfectly, like, what do you need to see? So there's a little bit of bleeding. So there's a little mastoid, cortical vein. So even if you get a little CSF leak, what's going to treat all that? It's going to be all treated by putting the implant in. It's putting a bung. You're putting something in there that's going to stop it up. So don't be too afraid if you get bleeding. Now, if there is bleeding, it can be a little hard to see what's going on. And if once you start bipolaring or bovying, then any kind of circular thing is going to start to shrink down. It's going to get very hard. You have to spread it open again. So it's not perfectly easy surgery to do, but if you can do chronic ear surgery, you can do this. This is how I set it up in the operating room. I have the patients face towards the anesthesiologist. So this is if we're doing the patient's right ear, their head is turned away. And sometimes that's a problem because that means their good ear is down. This is how I do local cochlear implants too. Just a good setup for any kind of local case. It's a little pain in the butt to have to cross your arms to have the scrub, but I'll honestly leave most of the instruments I need. I just lay on the Mayo right over here, and this Mayo is nice because you can drape up and over the patient. Your split drape. So you drape up and over the patient, and then under the Mayo, the patient and the anesthesiologist have full access to the airway. This is a 5mm skin biopsy punch. Very simple, very easy, very cheap. This is a patient here. And this is kind of the area. This is maybe a little further posterior than I usually put it. You want to put it close to the ear, but not too close. They recommend putting, I think, about 5.5 centimeters away from the posterior bony external artery canal, or 4.5 centimeters away from the postauricular crease. I kind of angle it up. Some people put them lower. I just find that it tugs more. There's more muscles, and when somebody's sitting in a couch or a chair, the closer it is to the occiput, rather than up towards the temporal area, you'll get a lot more feedback. Pillows, things like that. You can imagine somebody, if you're resting your head against a pillow, the pillow's sitting here. It's not sitting up here. It's sitting down over here. So placement is important. Then I just kind of mark it out. I inject around. I'll get to that in a minute. I don't inject the actual site that I'm going to do it. I do kind of a block. So you want to get it for hemostasis, and you want to do it for, you can see I'm using Marcaine here just because it's nice, it lasts longer. I don't like to inject the actual area I'm doing. So the darker blue is the area that I kind of infiltrate, and the lighter blue is not infiltrated. It works fine for hemostasis and certainly works fine for anesthesia. Then you prep with whatever your favorite prep is. I've gotten away from doing it with the Ioban. It's just too expensive. Just however you want to do it. You can do it for towels, clamps, really doesn't make a difference. I'm not dogmatic about that. I do think sterility is pretty important. Then you take your 5mm punch, blah, 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 straight down to the skull. And then you can see that it's not the best picture, but you could see just exposed skull right there. You may have to sometimes. Then you use your initial countersink 3 and then 4mm. Sorry, your initial guide drill. And then you kind of free, if there's any more soft tissue, periosteum that has to be freed away, do that. Try to avoid any bovie if you can. Heat is not good for this stuff. Then you do your countersink, which I don't think I did a picture of. And then you just put it in. I put pretty much everybody in at a torque of 50. And then I'll hand tighten if necessary. Now, because the implants themselves are about 4.5mm wide, or 4mm wide, but your punch that you're using is about 5mm, there's going to be a gap. That'll close up over time. But it tends to ooze a little bit. Then you can use an Alwyn dressing. I basically just use, I just put Zeroform around here. Cheaper is better. Sometimes in bigger people, or if you put the incision, if you find a spot and it's not a good place, let's say there's a vascular channel and you put it and you say, oh crap, that's directly under where I made my hole, but that's just not a good place. Extend the incision a little bit and then just close it up. Just fish mouth it a little bit. This is what it looks like, at a year. This is at a year. I mean, they're pretty good. I have to say that, and we published on this, is that the skin irritation is extremely low. It's not zero, but it's very, very low with this minimal technique, because I think the issue is not infection. When people get irritation, it's not because infection, it's because of a local skin reaction, almost a contact dermatitis. So people put antibiotics. Guess what? That doesn't work. Put steroids on it. I use clobetasol way more frequently for this than I do, which is a high potency topical steroid, way more frequently than I use antibiotics. Because the initial problem is not infection. We've studied this and looked at it as well. It's pretty good evidence to suggest that it's inflammatory but not infectious. Another person here.
Can I ask a question about that?
Sure. Yeah.
If you see someone who heals and then they have a delayed reaction after healing, do you do anything like culture it to determine?
I almost never do. Unless there's purulence, I never do. And even if there is, I just assume that they have they have MRSA just because they've been in the hospital or they're chronic. These are oftentimes not the healthiest people. So I just prescribe mupirocin topical if I think it's infected. But generally, I don't think these things get spontaneously infected. It's not a hygiene issue. If anything, the people who run into more trouble are the people who clean it too much. It's like brushing your gums too aggressively. It's going to get red and beefy and swollen. For postoperative care, I tell people just use like a baby wipe or some non-medicated hypoallergenic baby wipe, and just kind of, once or twice a week, just clean it up. Maybe a soft bristled toothbrush and keep it in the shower. But most of the time when it's delayed kind of infection, if you do think it's infected, I think that the primary process that started the restart of the problem is probably more inflammatory, almost like a more contact dermatitis. So if it's not super red or purulent, but it's just kind of beefy and angry, maybe there's some granulation, start with steroids. Even preparation H, which sounds crazy, but it's over-the-counter steroid with some decongestant in it, with some vasoconstrictor in it. So that's actually some people have had success with preparation H. If I say you just have that floating around at home. Not a great picture here, but you can see almost none, and these are all kind of years later. That's not to say that.
Question for you too. We use gentian violet. Some also calms it down. Thoughts about the HA versus just the titanium? What are you finding with what you do?
Yeah, I'm glad you asked that, Ted. I don't use the HA at all. My early experience my early inclinations was that it had way more problems. The skin starts to grow in, and kind of adheses. And so I never use, I don't think in the cochlear people don't want to hear this, but I exclusively use Oticon medical implants and abutments. And then the patients can pick whatever processor they want because cochlear will fit on an Oticon abutment. I do not like the Dermalock. But happy to discuss further with anybody who feels that it is good. But just even talking with friends, I'm not a big fan of it, and it sounds like they aren't either. So you'll notice.
Yeah, I agree with that statement, Dan. They're terrible.
Yeah, terrible. So I exclusively use Oticon for the implant abutment, and then the patient can pick whatever processor they want because it's universal. The opposite is not true, by the way. I'll come back to that in a little bit. You can't put an Oticon processor on a cochlear abutment. All right, we're going to talk about the passive transcutaneous just briefly because I think these are going the way of the dodo. The Baha Attract, which I again, did not like it just for a variety of reasons. The whole reason that people wanted to do this was to hear better, and they were concerned about having a bolt out of their head. My personal feeling was that this was actually bigger and more noticeable because not only do you have your processor, you have this external magnet outside, so it stuck out further, and the incision was bigger, and I just never a big fan of the Attract. Not to mention that the hearing quality was not as good as the percutaneous. I did a couple of Sophonos. Unfortunately, one of them was in a single side deafness patient. Just couldn't get the gain. Just couldn't get the volume out of these transcutaneous passive ones. So this is how it looks. And look, it just sticks pretty far up. And it was simple in theory. It was just a magnet on the inside, a magnet on the outside, and they'd vibrate. And the surgery was, very similar, just kind of a linear incision. Get back there. Put in these big magnets. I'm gonna skip this. So the percutaneous in general, I find are better. The shorter surgeries, more power, lower profile. I mean, look at these two, and you could say, well, I don't want a bolt sticking on my head like Frankenstein. Well, you wouldn't see a bolt when you're wearing it. You barely see it unless you've got super short hair like this guy. You wouldn't see it either. But I just thought, from a cosmetic point of view, granted, this guy has shorter hair than this guy does, but I feel like which one's more noticeable? Forget about it. This is just looking at the side view. Imagine if you looked at him straight on. This thing would look like an antenna coming out of his head. Certainly better retention for the percutaneous. But, you don't get that skin reactivity issue. I think the longer abutments and the minimally invasive, punch surgeries have made that a lot easier. And, of course, the cosmetics when not wearing, is an issue. This just goes to show you that the power that you get at the high frequencies is a little bit deceptive because it looks like half of this chart is from 100 to 1,000, but we know that this goes all the way up to 4,000, 8,000. But you're really in the higher frequencies and really in all the speech parameters and beyond, you're missing out on the passive. So that's given way. So there was a while there, probably through all the 2010s, really, where this is it. This is it. You had the Attract, and maybe you had the Sophono, and that was it. Not even going to talk about the sound bite. And this was it. How am I doing on time? Am I doing okay? Doing okay. So now we've got the Osseo 2, which is from Cochlear. Here on the left, you have the Bone Bridge. Now, the Bone Bridge was actually the first one to come out. So Bone Bridge came out in Europe and was approved in the US in the mid-2010s, definitely before the Osseo. And it has advantages, disadvantages. I'm going to get into that a little bit. The Oticon Medical one, which is not approved in the US, is very, very, very similar to the Osseo in terms of how it functions. So I'm not really going to talk about that too much. They basically work the same. The Bone Bridge, as I mentioned, was the first one to come out, and it was clunky, but it was cool because it was transcutaneous. The active part was inside the skull. The external part, I think it was the Samba processor, was relatively small, and patients like it. I've got a couple of patients who really like it. The audiologists don't love it that much because the software's a little clunky. But actually, it's a nice device to put in. Here's the incarnation. I think it was called the 601, and this is called the 602. And you can see that the CAN, the floating mass transducer, that's here was quite large. So you had to have a pretty big mastoid cavity to sink that into. And if you didn't have a mastoid cavity that was big enough, or they were already a canal wall down patient, you had to put it either retrosigmoid, which was uncomfortable for the patient and technically challenging, or you could put it in the middle fossa, which is how I do it, which is much easier. One of the nice things about it is that this is the old one, but this was the old one was almost 9 millimeters thick, and you had to recess that all down into something. That's a lot of brain compression in the posterior fossa, even the middle fossa too. But one of the nice things about this is that you can see here on the right, and this is still the case for the 602, is that you can angulate the head any way you want. So you can put this, you could still have, you can have, I don't know if you can see me on the picture here, but you can have, let's see if I've got a picture here. Yeah, so you could angulate this any way you want. So here this is in the mastoid presigmoid, and you could angulate the magnet and the receiver stimulator up this way. Or if you were putting it retrosigmoid, back over here, you could angulate it straight up like this, and you could have it anywhere from almost 90 degrees on either way, which is pretty cool. There's a little bit of a bend here, but it's not perfectly flat, but it's good enough, and you can recess it down pretty good. This is all you have to do for the middle fossa. I actually like the middle. If you could do the mastoid is probably the easiest. Just go straight down and just kind of make a 1 centimeter kind of a cylinder down into the mastoid right behind the ear canal. That's pretty easy to do. But honestly, the middle fossa, don't let the word middle fossa freak you out. As otologists and neurotologists, this shouldn't be scary at all. And it's a very small incision just like this. Make a little island, push it all down. Actually, I take out the little island here, bipolar away whatever's here just because you want it to bleed. And then this thing just sits right in there. And then you got these little, they have these risers if it sticks out too far. But usually it's not necessary. You can use one of those Penfields or a hockey stick or something that you would use for releasing dura to push this down a little bit. Then you can see here that this is totally angled backwards so that you're not forced to angle the bone bridge any direction. So then the Ossea came out, and at least in our clinic, that kind of was kind of a not great for the bone bridge because the software was much more familiar to the audiologists. Patients like that you can stream directly. All the end user capabilities that Cochlear is known for were available in the Ossea. I'm going to skip the video, but it's very similar to an incision you do for a cochlear implant, just without a mastoidectomy. And the gain is pretty good here. Sorry, this is blurry, but this is, again, from about a year ago before we had better data. I have to update this slide. But the gain's not the right word, but for our purposes, the volume that you're getting out of it is better. So what are the outcomes? They're good. I'm not going to bore you with a whole bunch of outcomes. There's been a zillion papers out there. Now, the percutaneous devices certainly have more data. They've just been around a lot longer. The rates of skin reactivity are much higher, but again, historically speaking, that's been the case because of the techniques that were used and the smaller abutments that were used. Generally, smokers are going to have worse outcomes. Kids are going to have worse outcomes. Obese people are going to have worse outcomes. And depending on your technique, it's going to make a difference. If you do that nasty skin graft, then you're going to have worse outcomes. I don't care how good of a surgeon you are. Older patients with transcutaneous devices is an issue, and this is true. We know this from cochlear implants. I'm sure you've all seen people who got their cochlear implants maybe in their 70s when they were robust, and now they're in their 80s or in their 90s, and they're frail, and they've lost a lot of subcutaneous tissue, but they still have the number 5 magnet on, and now the whole area where their magnet is completely squashed from the capillary action being exceeded, and now they've got skin necrosis in the area. Really, conductive hearing loss and mixed hearing losses patients are going to do better. Why? They just have better cochlear reserve. Sure, single-side deafness people like it. They just don't love it. I would say that on average, my conductive and mixed hearing loss patient loves their bone conducting devices. Single-side deafness patients like their bone conducting devices. Keep in mind also there's selection bias with all these patients because all these patients have tried hearing aids or they've tried bicross for the single-side deafness. They've all tried these things, so we're getting the pachinko of the people who have fallen through all the cracks and and are ending up with these devices. So there's a bit of a selection bias in terms of the how much these patients like these devices, but that's okay. That's the way the cookie crumbles.
But there's also, Dan, real quick, there's also a huge selection bias in, the single-sided deafness population of that's the device they've chosen to have, right?
Right.
And so, I mean, there's established literature on that, patients choose a particular, technique or something, they're always going to like that better.
Yeah, that's always the case. And many patients now these days more and more are coming in telling you what they want. I want a cochlear implant, or I want a Baha, or I talked to my Uncle Fred and he says blah, blah, blah. But yeah, there's huge amounts of bias when it comes to this kind of stuff, but that's okay. I don't think it's necessarily bad. It's just be aware of it when you're reading these papers. So now I'm going to talk to you a little bit about the tips and pearls that I've come up with on my own, and I'm be happy and thrilled to hear the people who have done these. What other tips and pearls you have? So the first thing to know is that although I only use the titanium BHX Oticon Medical implant and abutment, you need to know which processor the patient has selected, because it does make a little bit of a difference. The Baha clips into the abutment, the Ponto clips around the abutment, right? So notice up here, this goes into the socket, this goes around the socket. So if your skin is, can you see my pointer, guys?
Yes, we can.
Yes.
Okay. So if your skin is this thick and your abutment, forget about the skin that's inside your abutment. But if the edge of your abutment is only a millimeter proud of the skin, that's going to work out fine for your cochlear device because it clicks into the abutment. But your Oticon device is not going to work that way. So that will click in. This took me like 4 hours how to figure out how to do this on PowerPoint. That's no bueno, right? Because it's not going to click in because it clicks around the abutment. So you have to make sure that your abutments stick out further. I do not recommend skin thinning if you can avoid it on any patient with less than 12 millimeters of skin thickness. So this makes more sense because this clicks in, but notice how this one has more space around it to click around it. You can argue that because the Oticon clicks around it, that if it's not more proud, then you're more likely to get skin irritation and inflammation from the Oticon device. Yeah, that may be true. I mean, that makes sense. You just have to make sure it sticks out a little bit. Nobody's ever complained about their device sticking out an extra 2 or 3 millimeters, not to me. But they all complain if it's too short and you have to revise it, you have to do stuff. So don't skimp on choosing the length of your abutment. Measure your skin thickness before you inject, not after you inject. Measure before. A little pinprick, the patients oftentimes are a little sedated a little bit because, as you can see here on the right side, that although BMI does correlate with subcutaneous tissue thickness, it's not perfect. There are some outliers. So Oticon, and I think Cochlear makes one too. I love this thing. So what I do is I don't have a picture of it. Yeah. So what I do is before I inject, or if I'm really sure that I haven't done any of the center stuff, but usually I do it before I inject, I stick a needle in right where I'm going to put the abutment. I stick a needle in and then I clamp it with a I don't push down on the skin. I just right where it meets the skin. I clamp it with a needle driver, and then I hold it right up to this little ruler here. And it'll tell you what size to use. And if you're right at the border between one or the other, trust me, go for the longer one. Go for the longer one. And you can see that it's about, at 3, you can do up to 6. At 6, you can go up to 9. At 9, you can go up to 12. So it's because you want it about 3 millimeters proud of the skin. When it does come to inject, life will just be a little bit easier for you if you inject around where you're going to put the abutment, not an implant, not exactly where it is, because then you infiltrate it with all this stuff and it gets all swollen and juicy, and it's just hard. It's harder to do. Pearl number 4 is account for gravity. How many times have you seen people where you do these things and it bunches up? Some people are bigger people, and the ravages of gravity is that what's going to happen is that if you put your device in the center of this blue circle, what's going to happen is the as the person's upright, remember, you're doing surgery with them, or we mostly do surgery with patients completely supine. I like to do the patient sitting almost bolt upright if possible, at least 45 degrees if they can. And oftentimes I'll just do it in the stretcher, just to save time, have them come in the stretcher, do it in the stretcher, leave in the stretcher. But what's going to happen is that skin is gonna sag because of gravity, posteriorly and inferiorly. So that skin is going to shift. So you have to put your implant a little further posterior and inferior than where you think it's going to end up. So within that hole, that 5 millimeter or 6 millimeter hole, do it in the posterior inferior hole, because what happens is it's going to go this way. Otherwise, it's going to bunch up. Does that make sense? This is the full extent of my animation skills on PowerPoint, but it's going to bunch, and you're going to get bunching up in there. And then some people have to kind of like go like that to lift up their fat roll to plug their thing on. So this goes to what I was talking before, that a cochlear Baha processor will fit on an Oticon medical abutment, but a Ponto processor will not fit on a cochlear Baha abutment. So Oticon, in their infinite wisdom, in order to get people to use the Oticon abutment on their cochlear, Oticon processor on a cochlear abutment, said, oh, we're going to make this cool little adapter here, which sounds great, but unless you have any kind of legal mind whatsoever, and you can say, you can't do that, man. That's like hijacking our thing. And sure enough, this was the result of that, and that all got shut down. So there are patients who will say, I have a cochlear device, but I want the Oticon medical. That's more problematic than if somebody says, I have the Oticon medical and I want a cochlear device. For streaming. Remember, it's like an arms race, just like with cochlear implants or really any kind of technology. Different companies are going to come up with different advances over time. So at any one given point in time, one company may be able to offer more bells and whistles than the other. Pearl number 6, put the implant as close to the ear as possible. Now, will it work if you put it right here? Yeah, it'll work. Will it work if you put it here? Yeah, it'll work. Obviously, those aren't great from a cosmetic point of view. The closer you have it to the ear, the more transmission you're going to get to the cochlea. That being said, not to mention, and there's reasons for that in terms of volume and timing and intraoral, calculations that your brain is doing. But also, you don't want to have it too close. You don't want it touching the auricle. You don't want hats touching it. I have patients bring in hats and glasses with them, if not to the operating room, but certainly to the pre-op area. Wear your hat. What's your favorite hat? Bring your favorite hat with you. And then I mark it out according to where the hat is. General anesthesia is generally not needed unless you're doing it in conjunction with an acoustic or something else like that. Straight local's fine for most patients, especially older patients. I find that, give them propofol and they fall asleep, and that's great. But if there's not enough, then they come back and they're disoriented, and, it's only an 8-minute procedure anyway. So imaging is generally not needed. Like I said, if it's I'll put a 4 millimeter implant in for pretty much everything. It's helpful for the bone bridge. I don't think it's necessary for the ossia. It's certainly helpful for a bone bridge to give you an idea of how much mastoid you have to work with. You don't want to make a regular posterior auricular incision with bone bridge and then discover that you've got a really anterior sigmoid and then have to figure it out from there. And then you're going to end up with some ugly looking scars. I talked about this just a little briefly also, is that skin reactivity is much more likely inflammatory rather infectious. And your first line treatment should be steroids, not antibiotics. And that overcleaning is oftentimes just as, if not more problematic than undercleaning. Transcutaneous, again, watch for skin compression and strangulation as the patients get older. Another pearl I didn't add on, which would be my last one, is that, and I'd love to hear your guys' take on it, is that I was really excited about the ossia, but I just don't like where it sits. The curvature of the skull and the curvature of the mastoid kind of occiput makes it so that it's really prominent, and so I've been putting the osseas higher so that now the magnets are almost, kind of up here, almost parietal, almost where the squamosa kind of is up higher. Because if you put the ossia too far low down, it's great that the osseointegrated, part is down there, but I just find the curvature of the skull for most patients makes it pretty lumpy and uncomfortable, and it's just kind of a chronic uncomfortable that the patients have that they're willing to deal with because they like the hearing, but it's not a surgery that I love.
And are you doing osseas on people who have chronically bad mastoid bowl problems or other reasons?
Yeah, I mean, we kind of, I mean, I have a little bit more of a bias towards the percutaneous, the more I've been doing the transcutaneous. But our audiologists show everybody everything, you know, once they're in that pathway. So yeah, if they meet the indications, I'm more than happy to do the Ossia for chronic mastoid, for medial canal fibrosis, for whatever.
I think the majority of, I don't do a ton of these, but I think the majority of my bone anchored hearing apparatuses are for people who have really bad bowls, chronic issues,
Yeah.
And I
end most of them, because otherwise you can wear a hearing aid, you know.
And end up closing them off. And
yes.
Challenging because yet another surgery, lots of swelling, lots of drilling way far back, weird angles, etc. So yeah, we've had to place them in some interesting positions from my standpoint as well too.
Yeah, these things are tools, you know, they're tools in your toolbox that you can use oftentimes with conjunction with other surgeries that are not a fix for everything. You know, sometimes just not wearing the hearing aid is what gets their mastoid clear, but if they can't hear, you got to do something. But it's great for those situations. There's some mastoids you just can't get clean and they just can't hear, and a hearing aid is just not an option for them. So yeah, that's more or less my my spiel there. Hopefully I made it a little more exciting than the perirectal abscess of otology. But in the end, I think it's these are devices that pretty good bang for the buck, considering that they're, you know, 8-minute procedures. Patients are generally pretty happy.
Awesome talk, Dr. Coelho. Thank you so much. Just one clarification. You were talking early on in the talk about your process, and I think I heard that you use just a 4mm implant pretty much for everybody. Did I hear that right? And do you actually measure do you do the 3 and then check if you've hit dura and then go to the 4, or do you bother with that?
Yeah, I'll do the 3. If I hit dura, I'll still do the 4mm countersink. And still put a 4mm implant in. If it's super duper thin, if it's like 2mm, then I'll probably find a different place. I'll look for a different place. But if it's 3mm, I'll still put a 4mm implant in. I mean, you're compressing firm leathery dura by 1mm. You know, not a big deal.
Okay.
The financial aspects of this are interesting and getting more complicated because they're trying to add in new codes for transcutaneous. It's a heck of a lot more work, but as you guys know, there's only so much. The pie is only so big. So if you rob from Peter, you're going to have to pay Paul. So, you know, we love saying, oh my gosh, this is great. We used to take an hour and a half to do these nasty skin grafts, and now we're getting paid the same amount to do these 8-minute procedures. Well, that's going bye-bye because all the money that you would have been making with the percutaneous is going to the you know, is probably going to be split with the transcutaneous, but that's okay. But it's certainly getting confusing, and not to mention the insurance companies don't even know what these are in the first place, and once you start having the other things. We've also had some success. Sorry, I'm just going to keep mumbling and talking until you stop me. But we also use the bone conducting adhesive solution. The Adhere is something that I don't know if other companies make it, but Med-El makes something called the Adhere. We've got a handful of patients with those who have more mild conductive hearing loss, don't want to wear a hearing aid for whatever reason, or can't. Those are nice bone conducting options that are non-surgical. But really only for kind of mild to moderate conductive hearing loss. That's it. That's all I got.
So I think, you know, some things that come into play that you don't really think about, but, you know, when it came to the introduction of the Ossia device, you know, they came onto the market with a 10-year warranty for the device and the whole whole thing, and that
Mhm.
really kind of was an aggressive commercial push that
Yeah.
kind of really, I mean, despite the fact that it was second on the scene. So these are things that as a surgeon you don't really think about, but when it comes to a patient standpoint, that's a
Yeah, that's
huge,
right.
huge thing. If you have a broken processor, so you have to pay for that out of insurance, at high deductible, or out of pocket.
Yeah.
And that really kind of was a big push for Cochlear.
Yeah. I mean, a lot of things, even the fact that, no streaming, no intermediary streamer for it, big warranties. They're smart. These companies are smart. They're going to try and get the business and direct marketing
And
to
that
patients.
and the user interface is consistent, just for everybody out there. Kind of the same with the cochlear implant.
Right.
The metal cochlear implant is by far the least user friendly,
Right.
from a consumer standpoint and from an audiologist standpoint,
Right.
of all the devices out there.
Yeah. I mean, we are also, most of us are hesitant to say, hey, I don't choose. I'm just a surgeon. I'm not involved in the selection of the implants. The patient and the audiologist choose that. We like to wash our hands of that. But in some cases, it's okay. I mean, I found that I was a adopter with the Ossia, but with more experience with it, I'm less. I like it. I think it's good for some patients, but I'm not as gleefully enthusiastic about it as I was in the first couple of months.
That kind of reminded me of another point that I wasn't aware early on of the Ossia's non-use of rechargeable batteries. I think I have that right. That the battery life is not great. Do you hear from patients about issues regarding that?
Yeah, I mean the active. I think all the active devices, the active transcutaneous devices, all use up batteries faster. But almost everybody, I shouldn't say that, but 100% of the people who have experience with hearing aids are going to be disappointed with their battery life, no matter what they choose. My hearing aids used to last me 5-6 days. This thing only lasts me 2 days. Well, yeah, I mean it's using a tremendous amount of power. But I say that's the cost of doing business. I do talk about that with patients beforehand, especially hearing aid users, because it's like it may be covered by Medicare, but you better budget for some more hearing aid batteries. Yeah, they're interesting devices.
Well, if we don't have any more questions, I think we'll end it there. Dr. Coelho, thanks again so much for joining us. This was awesome.
Yeah, my pleasure. Thanks for having me, guys. Good to see y'all, and hope to see you in person soon.
See you, Dan. Thanks.
Bye, guys.
Thanks, Dad. Hope you're doing well.